may I, in the meantime, tell you that the next session is on the tower, and a lot of interesting cases will be shown. And the chairpersons, rather moderators for the next session are Dr. Ashok Seth, Dr. P. Sirat, and Dr. Srinivas Kumar. Are they there?
Hello. Hello. Can you hear?
Can you hear us?
Yeah, good evening.
Yeah, we can hear you, Ashok.
Oh, good.
Yes.
Good.
Yeah, we are not yet seeing you. In a moment, we will see you. May, in the meantime, let the first speaker be ready.
We can see Dr. Seth.
Oh,
Okay.
Good.
Thank you, all of them.
So should we start? And
Yes.
yes, we are 10 minutes behind time, and I think we
Please
would
go
ask
ahead.
Sai Satish to take on the first talk on TAVR, coronary artery disease in patients with aortic valve disease. So Sai, over to you.
Hi, Dr. Seth. Hi, Dr. Sharat Chandra. First of all, thank you all for having me here. It's so nice to actually see faces after being cooped up, seeing walls and things. I'm so glad to be here. Just one small thing. I'm going to be presenting tomorrow's topic today, and I just took the permission from the organizers to swap it out. I had some technical difficulties. I hope that's okay. It's also a TAVR case. I thought it would be nice to start off can you guys see my screen?
Yes, we can.
Yes.
Okay. So I thought it would be nice to start the TAVR session with a fun TAVR case. Hi, Ramesh. Lovely seeing you. Hi, Dr. Rat. Hi, Srini. So I'm going to jump right in with requests because of time.
Go ahead.
I call this case Murphy's Law. And the reason I say Murphy's Law is that it reminds me that when things go wrong, when there's a possibility for things to go wrong, they always go wrong. So 74-year-old lady, 5 foot 5 inches, 107 kilograms, no diabetes. No, just 1 second. Just 1 second. That's perfect. Just had to move the screen. So 74-year-old lady, 5 foot 5 inches, 107 kilos, no diabetes, a hypertensive on treatment, presented with syncope, severe aortic stenosis, mean gradient was 97. The CT showed and the echo showed a Sever's type 1 bicuspid aortic valve. She had a normal LV function. So this was her CT analysis. As you can see from the procedural considerations, it was a type 1 bicuspid, and all the measurements, 67, 65, 65. So across board are in favor of a 26 valve. Is my screen clearly visible, Dr. Seth?
Yes, very clear.
Yes, it is very clear.
Right.
Okay. So this is the next set of images. As you can see, all the measurements are conducive for a 26 millimeter valve, the sinus size, everything else. And there is a nasty septal bulge. I hope you can see it right here. There's a nasty septal bulge here. And the femorals, of course, were large enough. And then we start the case. So I've put #1 for each mistake that keeps going on. So you'll see the numbers going up. So start, just 1 second. There we go. So started off with 2 TPI pulse generators not working in the lab that day. So managed to get our EP in, screwed in a PPI lead via the IJV and put an external pulse generator. We were determined to do that TAVR that day. Clean femoral, but wrong puncture was from the site, so had to actually redo it. Perclose would not track. As you know that she was a 5 foot 5 inch, 107 kilo lady, so huge thigh. So the perclose got stuck, so we had to put a stiff wire in, managed to get both the percloses in place, and then got the 18 French sheath in. You can see with some difficulty. It's moving up. So this is the root shot. And once we have crossed the valve, we're getting the pig in place. With that huge septal bulge and small LV cavity, you can see it was quite difficult to get the pigtail right at the apex of the LV. And you really want the pigtail in the apex of the LV before you get your stiff wires in. And I have no one to blame here. All this is me. So you can see while trying to push the pigtail in, you can see what happened to the pigtail. It went down to the LV apex, but buckled in two. Is this fast enough, Dr. Seth?
Yes, this is good.
Okay. I'm still getting used to looking at screens and talking. So getting that pigtail out of
Right.
that stenosed aortic valve. As you can see, it was not fun. I didn't want to push the wire and break that piece off inside the LV. So I'm just going to let this play out so you can see how it troubled me. So the pigtail is out. There you go. And then bring it back to the large sheath. And of course, spin it around. Then finally that is done. So start again fresh, recross the valve. And the pig is stuck in the mitral apparatus. So you can see how I'm using the wire, getting the pigtail all the way to the LV. I love the position of the pigtail, got the confida in place, did the BAV. So good position, good coaxiality with wire manipulation. You can see the wires pressed around the LV apex. The TE is okay. I hope you're happy with where it is. Hi, Sushil.
Yeah.
Okay, so that's where it was. And after releasing the valve, just keep watching the valve. I'm doing nothing. It just milks up and pops out. You can see it on the image on the right side. The nose cone is far away. Just, there you go. So torrential AR, barely stable, rapid pacing. And in between all this, the wire escapes the LV. So, and to add to all this, the second valve that's reloaded is also a misload. So we're at mistake 10, I think, now. So I commandeered the right radial, went in with a 35mm stair, but it took forever to finally catch something. You know, sometimes it's amazing how seconds seem like hours, and with a lot of difficulty managed to hold on to something. Pull the valve up, and I quite like to do this. I like to pull the valve just above the coronary ostia because I like to use the outflow of the first valve to support and hold the second valve in place, especially in these huge septal bulges. So the valve is right where I want it, taking the second properly loaded valve in, and just look at what happens. So it pops right out. So start again from fresh, move the valve into the descending aorta, and I caught everything. I tried from above, I tried from the side, I even caught the damn pigtail. Sorry for the French, but I caught everything but that valve paddle that day. Switched to a fancy 3-pronged snare, never used that before, that wouldn't catch anything. Finally switched to femoral, managed to catch the paddle. As you can see, the valve is securely held in place. The new valve goes in. With TE, with fluoro, this valve was put a little deeper intentionally, a little deeper into the LV so that the outflow can nicely sit in the inflow of the previous valve. Checked everything. Once we were happy with the position, let the valve go. TE looked great. So finally, great position, valve stable, good hemodynamics, peak to peak 6, mild AR, flowing coronaries, no mitral impingement, patient in sinus. And you would think this is over. Femoral closed off. So crossing it with a coronary wire, no peripheral equipment. So took whatever balloon we had, tried opening it. Still the stenosis was significant. I was not too keen on stenting it, but not left with much choice. Finally got a 4mm coronary stent down there. And this was the final result. Thank you all so much. The really fun thing about this case was that it was my first proctoring, first international proctoring, first case for the country, and everything I could possibly think that could go wrong went wrong all in one case. Thank you all so much.
Yeah, no, that's a great demonstration, Sai. I don't know whether we have time for discussions on this, but it really does require 5 minutes of discussion. And the real issues which I wanted to discuss with you were that I think that you were trying to push the valve at 0. And I think that it can happen that when you're 2-0, that you're actually -1, and then it squeezes out, should we say. When you actually have the inverted funnel, it has less likelihood of squeezing out. But when you actually have a symmetrical, then you actually, if you try and position to 0, that's when it squeezes out. So I'm not very keen when you have this horizontal type of a bicuspid, then I'm not very keen on 0. I'd rather have 1 or 2. And it's less of a concern as far as septal bulge is concerned, but more of a concern of popping out.
So the thing about this case was, Dr. Seth, if you see the measurements at the annulus 5 and 8 millimeters,
they
it
were
was
all
fairly
symmetrical.
same. It was all symmetrical. And I didn't go for 0. Those were my earlier days, and I went for about 3 mm. Okay. But because I had a 2 mm gap, and I usually like to leave it above the bulge, and it looked stable, but it just happened.
Okay, so it wasn't 0 you were aiming for.
No.
Dr. Satish, can you tell me when the valve puffs up, where you actually want to bring it down with the snare? What is the ideal place?
So I mean, there's Sushil there, and I think Ramesh is there and all. But what I like to do, Dr. Rat, is I like to keep the valve just above the coronaries, because if I bring it too high up, I don't want it flying around in this aorta. It can cause dissections and it can float away. So I actually like to interlink both the valves that I'm going to put. So my valve that's across the annulus holds this valve safely, and this valve keeps that valve a little in place. This is what I like to do. Dr. Seth, Dr. Chandra,
Yes.
what do you think?
I think what you did
Yeah,
was...
so I think, it, as a starting point, your day was not a very good day, because with you, I don't expect any such thing to happen. You are a fantastic operator.
Thank you so much.
And the only thing I think to starting was that the movement of the wire and the nose cone actually just pulled out the first valve, and then of course you were engaged in pulling it out and keeping
Everything
it in position.
else followed.
But certainly, I think it was very well done.
Thank you so much.
Yeah, let's go to the next presentation, Dr. Ashok. And before that,
Sure.
let me just request Ashok, at the end of today's all the cases, Dr. Rajneesh Kapoor will be also presenting a case of TAVR.
Okay, so
Kindly
I think
invite him.
then we should move ahead, because okay, so that was Sai's presentation, and we've got a next one. Sai, this was the only presentation, isn't it? You're not presenting anything else.
That's it, Dr. Seth.
Okay, great to see you then. Now we have Dr. Singatuvelu. Yes, it is. How to predict and manage delayed coronary obstruction after TAVR, and that's by Singatuvelu.